what are the most important types of cardiovascular diseases or disorders that you patients might have? The first is high blood pressure. What's the definition, the current definition of having high blood pressure? How about a blood pressure greater than 140/90? If a normal blood pressure is 120/75, 120/80, if somebody has a blood pressure greater than 140/90, they're said to have high blood pressure. You need to know that. I'm sure you did. Because when you take somebody's blood pressure, you want to be able to tell them that they've got high blood pressure. Angina pectoris. We'll talk more about that, but that's that pain that's felt in the left shoulder because of myocardial ischemia. Not enough oxygen to the heart muscle. CVAs. A CVA, which stands for cerebrovascular accident, is where there is a problem with blood flow to the brain, cerebrovascular. And what's the more common term for CVA? A stroke. That's what a stroke is. And heart failure. The definition of heart failure is decreased cardiac output. So cardiac output is the volume of blood ejected by your heart each minute. When that volume of blood ejected by your heart each minute becomes less than normal, that's called heart failure. Now, cardiovascular diseases are very important. They are the leading causes of death. More than 25%, more than 1 out of every 4 of the top 200 drugs prescribed are for cardiovascular problems. About 25% of all prescriptions. In terms of how cardiovascular disease relates in the context of dentistry and dental hygiene, I think this follows what you've been taught already, that you don't want to see anybody unless it's been 3 to 6 months following post the myocardial infarction. Is that right? So an MI, a myocardial infarction, is commonly called a heart attack. Uncontrolled angina pectoris. If somebody has a history of angina, you want them to either have taken their medication before they come in to see you, or they've got their medication with them. Because you don't want to have them have an anginal episode right there. And one of the things that can trigger it is the stress of just being in a dental office. Uncontrolled congestive heart failure. Again, if somebody has a history of congestive heart failure, you either want them to have taken their medication before they come in for their visit, or they've at least got it with them. Uncontrolled cardiac arrhythmias. If somebody has an arrhythmia of their heart, you either want them to have taken their medication before they come in, or they've got it with them. Uncontrolled high blood pressure. If they have that, you want them to have taken their medication either before they come in, or they've got it with them. Some cardiovascular cautions for dental treatment. Of course, any history of infective endocarditis or rheumatic heart disease, you have to treat them more carefully. Because every time they get a strep throat type of infection, it triggers a new onset of this autoimmune attack on the endocardium of their heart and the valves of their heart. They no longer require you pre-medicate them with an antibiotic, but you still have to deal with them cautiously. Any patient with a heart pacemaker, this is not the problem that it used to be. They used to say that if you needed to either avoid using or use ultrasonic scalers with caution. Nowadays, they believe they have greater shielding of the electromagnetic field created by an ultrasonic scaler, which in the past used to interfere with the battery for a battery-powered pacemaker. If somebody has a history of cardiovascular problems, you should double-check their blood pressure. Now, again, this is what you're supposed to do. I'm going to say something that I think you've all learned. In your program, you are taught ideally what you're supposed to do. In the real world, you will see that we don't always do what you were told to do because things have to move quickly. Time is money, and they don't want you spending, an hour and a half with your patient. And this is true with a lot of stuff where in real life, you kind of take shortcuts. but at least you're supposed to be taught ideally what's supposed to happen. And so you should take somebody's blood pressure ideally before you do any procedure. You should be aware of the following: xerostomia, because many of the medications they're on cause xerostomia. Dysgeusia, what did we say that was? A funny taste in the mouth. Some of the medications cause dysgeusia. Some of the medications, specifically digoxin, increases the gag reflex. Some of the medications we're going to mention, specifically calcium ion channel blockers, can lead to gingival hyperplasia. Many of the drugs they're on can lead to postural hypertension. This is a side effect of being on these drugs to control high blood pressure. And many of these drugs that they're on cause CNS sedation. They make them feel fatigued and lethargic, especially these beta blockers. The next page, E2. The first class of drugs we're going to speak about are the anti-hyperlipidemics. What are those? They are drugs that lower cholesterol levels and triglyceride levels. And the whole purpose of this is to reduce the development of atherosclerotic plaque. Now, before I start to tell you about the drugs that they're on, let's give you a little bit of background about this problem. So let's take a look at page that form the wall of the artery, just like it's needed by all cells. So there's nothing wrong with having this protein that transports cholesterol to cells. However, if you have excessively high levels of this lipoprotein, that means the person will transport excessively high amounts of cholesterol to the walls of their arteries, leading to atherosclerotic plaque. So the LDL is commonly called the lethal lipoprotein. The bad one, the low down, dirty, bad one, the lethal one, because too much of it means you will transport excessive amounts of cholesterol to the walls of the arteries. Interestingly, our liver also produces HDL, high-density lipoprotein. If the LDL one is the lethal one, if you have too much of it, the HDL is called the healthy one. It actually is produced by the liver, and high-density lipoprotein goes out to the walls of the arteries and actually transports the cholesterol back to the liver. So it actually takes the cholesterol from the walls of the arteries and brings it back to the liver. Now, normally there should be a normal balance between these two lipoproteins. There's a normal balance. There's a right amount of LDL and the right amount of HDL. But some people, largely because of genetic factors, have excessively high amounts of LDL or excessively low amounts of the HDL. In either case, they tend to accumulate excessive amounts of cholesterol on the walls of their arteries. Now, what's normal? So I'm not asking you to know these numbers, but I'm sure you've run into people where they talk about these numbers. So this is the classification. The goal here is to have an LDL, that's the lethal one, the bad one, of having it less than 100, and the units are milligrams per deciliter. So we should have, when they run blood tests, and anybody who has blood tests now, they check the LDL and HDL levels, the LDL level should be below 100. And here's what they talk about. This is above normal, this is borderline high, this is very high. So that's what they talk about, the so-called, quote, bad cholesterol, or the LDL level. On page E20, the total cholesterol level, the desirable should be less than 200, and the units are milligrams per deciliter, or per 100 milliliters. So the normal cholesterol should be below 200. And incidentally, as we'll see shortly, if somebody has a history of either a heart attack or a stroke, then they want their cholesterol level not at below 200, they actually want it 150 or lower if they've had a history of having a heart attack or stroke. So anytime somebody starts to show they've got problems, they want these levels even lower. And the medication that we're about to describe change these levels. The borderline high is 200 to 239, and a cholesterol level greater than 240 milligrams per 100 milliliters or per deciliter is considered a very high cholesterol level. HDL, now that's the good one. So they show that the big number, the important number, is if the HDL level is less than 40. Frankly, there doesn't seem to be a problem with having HDL high, being on the high side. There's nothing wrong with the HDL being high. The concern is that this healthy one should not be too low. It's the protein that transports cholesterol from the walls of the arteries back to the liver. Now, there are a whole bunch of risk factors. These are summarized down here. These risk factors tend to increase the risk of atherosclerosis and heart problems, and that includes cigarette smoking, high blood pressure, low levels of the HDL, high levels of the LDL, family history of coronary heart disease, or also known as coronary artery disease, and just getting older, all right, is a risk factor. So just thought I'd draw that to your attention. Don't get older. There's a lot of other information here that you can take a look at, but we're going to summarize this in a moment. All right, here it goes into all this as far as lifestyle changes and risk. This is very high. So that's what they talk about, the so-called, quote, bad cholesterol, or the LDL level. On page E20, the total cholesterol level, the desirable should be less than 200, and the units are milligrams per deciliter, or per 100 milliliters. So the normal cholesterol should be below 200. And incidentally, as we'll see it shortly, if somebody has a history of either a heart attack or a stroke, then they want their cholesterol level not at below 200, they actually want it 150 or lower if they've had a history of having a heart attack or stroke. So anytime somebody starts to show they've got problems, they want these levels even lower. And the medication that we're about to describe change these levels. The borderline high is 200 to 239, and a cholesterol level greater than 240 milligrams per 100 milliliters or per deciliter is considered a very high cholesterol level. HDL, now that's the good one. So they show that the big number, the important number, is if the HDL level is less than 40. Frankly, there doesn't seem to be a problem with having HDL high, being on the high side. There's nothing wrong with the HDL being high. The concern is that this healthy one should not be too low. It's the protein that transports cholesterol from the walls of the arteries back to the liver. Now, there are a whole bunch of risk factors. These are summarized down here. These risk factors tend to increase the risk of atherosclerosis and heart problems, and that includes cigarette smoking, high blood pressure, low levels of the HDL, high levels of the LDL, family history, coronary heart disease, or also known as coronary artery disease, and just getting older, all right, is a risk factor. So just thought I'd draw that to your attention. Don't get older. But let's look at page E26. And on E26, circulating in our bloodstream are these little guys called blood platelets. And blood platelets or thrombocytes are good guys because when we cut a wall of a vessel, the blood platelets aggregate or attach to the cut edges of the vessel. The blood platelets then release. The blood platelets form a little platelet plug, and they release a chemical called PF. What's PF? Platelet factor. And platelet factor is what initiates a chemical reaction right there in the bloodstream, culminating in the formation of a fibrin clot. So what forms is a fibrin clot? And a fibrin clot looks kind of like a spider web, and it's made out of a protein called fibrin. So one of the chemical factors that triggers or causes this fibrin-like clot to form is a chemical called platelet factor released by the blood platelets or thrombocytes. This is also known as the extrinsic pathway in blood clotting. Now, what happens is next, the purpose of the clot was to stop the blood from flowing through this cut vessel so you don't bleed to death. And then what's going to happen over the next few days is that the cells of this wall of the vessel will undergo cell division or mitosis. The wall of the vessel will be repaired, and after the wall has been repaired, as you can see in the bottom picture, the healed wall releases a chemical called tissue plasminogen activator, or TPA, and this chemical, TPA, released from the healing wall of the vessel, activates another protein circulating in our bloodstream called plasminogen, turns it into plasmin. And plasmin is a protein that dissolves this fibrin clot. So plasmin is plasminogens turned into plasmin, and it dissolves this fibrin clot. Breaking apart, dissolving this fibrin clot is called fibrinolysis, breaking apart the fibrin clot. And when the fibrin clot dissolves, blood can now flow through this repaired vessel. Everybody okay on that? I know you've heard all this before. Look on the next page, E27. All right, so why did I review blood clotting with you? Here's why. When somebody develops atherosclerotic plaque on the walls of their arteries, when they have this fatty plaque with cholesterol and fat and calcium on the walls of their arteries, these circulating blood platelets attach to the rough surface of this atherosclerotic plaque. Remember, the platelets are designed to attach or aggregate to rough edges, such as those caused by cutting a vessel. So in this case, no blood vessel has been cut, but the rough surfaces of the atherosclerotic plaque cause the platelets to attach. The platelets that have attached release this PF, this platelet factor. Platelet factor initiates, it causes the formation of a fibrin clot. But wait a second, why are we forming a clot here? This vessel wasn't cut. So when this blood clot forms in an atherosclerotic vessel, not because the vessel was cut, but because of atherosclerosis, this is called a thrombosis. A thrombosis. If this thrombosis or blood clot that's forming in this atherosclerotic vessel, this artery, if this occurs in a coronary artery, it's called coronary thrombosis. If this were to occur, this formation of this blood clot occurs in an atherosclerotic cerebral blood vessel, that would be called a cerebral thrombosis. Now we've got a problem. Blood can't flow through this vessel, and it's not because it was cut. If oxygenated blood can't flow through a coronary artery, the heart muscle will die from lack of oxygenated blood. If the oxygenated blood can't flow through a blood vessel in the brain will die from lack of oxygenated blood. When the heart dies, that's called a myocardial infarction or heart attack. When the brain dies, that's called a cerebrovascular accident, a CVA, or a stroke. So what we're submitting is that the #1 cause of death, heart attacks, and the #3 cause of death, strokes, have something in common. And the problem is atherosclerosis, atherosclerotic plaque. Now, in fact, one of the things that they sometimes give to patients who are in the process of having a heart attack or a stroke if they can get them to the hospital fast enough, they actually administer to them the same chemical, TPA, that our own walls of our vessels release to activate this protein in our bloodstream called plasmin to dissolve that fibrin clot. And that's what they give them, this TPA, tissue plasminogen activator, to try to dissolve that clot. And so we see there's really two major problems that happen, at least two, with the development of this clogging up of the arteries with atherosclerotic fat. First off, we focused on blood platelets attaching to the atherosclerotic plaque. But let's even forget the blood platelets for a moment. As more and more fat accumulates on the walls of these arteries, what's happening to the size of the lumen, the passageway for blood? It's narrowing. So what we're seeing is a stenosis or occlusion. Those words both mean the same thing. There's a stenosis or occlusion of the lumen of the vessel, which results in what effect on the amount of blood flowing through that vessel? How does that affect the volume of blood flowing through that vessel? It's going to decrease blood flow. So even if there's no blood clots forming, there's a reduction in the flow of blood through that vessel. So if somebody's developing atherosclerosis in the walls of their coronary arteries to their heart, or to the cerebral arteries to their brain, they're experiencing a reduction in blood flow to their heart or to their brain. The second major problem is that this rough surface created by the atherosclerotic plaque increases the probability of a thrombosis forming, a blood clot forming in the vessel, because the platelets are designed to aggregate or attach to this any rough surfaces, and that they release a chemical called platelet factor that initiates this chain reaction, culminating in the formation of a fibrin clot. Once a fibrin clot forms, there is no blood flowing through that vessel, and that leads to the death of tissue. And the term we use for when a tissue dies is either necrosis or infarction. And so this can result, therefore, in a myocardial infarction or a cerebral infarction or wherever this thrombosis occurs. So, with that as the backdrop, we see that it's important to reduce atherosclerotic plaque. Let me do one more thing before I develop that further. Let's go back to the previous page, E1. And on the bottom of E1, let me write something to try to show you, basically I'm going to take a very complex subject and try to really simplify it down to something pretty simple. It's generally believed that this atherosclerosis is the underlying problem for all kinds of stuff. Atherosclerosis results in decreased blood flow to tissues, and that leads to ischemia to the tissue. Ischemia. What's ischemia? Lack of oxygen to a tissue, as I just described. Furthermore, atherosclerosis increases narrowing of the vessel. This occlusion of the vessel leads to an increase in total peripheral resistance. And this increase in total peripheral resistance leads to an increase in arterial blood pressure. This increase in arterial blood pressure increases the workload on the heart. And this increased workload on the heart increases the probability of what's called heart failure. Or congestive heart failure. So what I'm basically suggesting is there's a kind of domino effect, a chain reaction, that as this fatty plaque accumulates on the inner walls of the arteries, not only is it reducing the flow of blood, oxygenated blood, to any particular tissue where this atherosclerosis is occurring, but it's raising total peripheral resistance. Now, if you're still kind of confused about, like, what does that actually mean? I don't get it. Think about this. If the vessels are getting all clogged up, is it becoming easier or more difficult for the blood to flow through the vessel? It's becoming more difficult because there's the lumen, the passageway is getting narrower. So this is an increase in total peripheral resistance. It's increasing the resistance, the difficulty of the blood to flow through these clogged up vessels. Just imagine if our plumbing, if our pipes were all rusted and clogged up, that would reduce our water flow, right, through the pipes. Anyhow, this has the effect on our vessels of raising blood pressure, and it increases the workload on the heart. And in case you're thinking, like, I don't understand, why would clogging up of our vessels, increase in blood pressure, why would that make our heart have to work harder? Think about this. The heart's job is to push the blood through the vessels of our body. If the vessels are getting progressively clogged up, can you visualize that the heart is going to have to work harder to push the blood through these clogged up vessels? So this makes the heart work harder. And while the heart may be able to work harder for 6 months, a year, 5 years, eventually the heart starts to fail because it just can't work harder than a normal heart should have to work 24 hours a day. And that's what you're making the heart do, is work harder 24 hours a day, 7 days a week. So eventually, in this domino effect, it leads to heart failure. So we're basically saying that the general theory is that atherosclerosis is the underlying cause of most types, not all types, but most types of high blood pressure, and ultimately the increase in blood pressure leads to heart failure. So if this is a domino effect, the moment they start to see elevated cholesterol levels, elevated LDL, low-density lipoprotein levels, they feel that this is going to lead to this domino effect, so they want to try to lower the cholesterol levels immediately. For some people, they already have high blood pressure. It's already progressed to elevated blood pressure. That means that not only do they need drugs to lower the blood pressure to reduce the workload on the heart, they still have to continue to take drugs that lower the cholesterol levels. For some people, it's way too late. They already have heart failure. And we will see that one of the medications that people with heart failure take is digitalis. Digitalis or digoxin can be used for other purposes other than heart failure, but certainly that's one of its uses. So if somebody is taking digitalis, it's also likely that they've got high blood pressure and they're taking anti-hypertensive drugs, and of course they're taking drugs like Lipitor to lower their cholesterol levels. So the further along you are in this domino effect, the more medications they put you on. All right, so with that in mind, on page E2, so on E2, so how do we reduce this atherosclerosis? So the most common drugs used to lower cholesterol levels are clinically called the HMG Co-A Reductase Inhibitors, or commonly just called statins. And this includes the most prescribed drug in the United States, the #1 or #2 most prescribed drug in the United States, atorvastatin, which goes under the brand name Lipitor. There are a whole bunch of drugs in this class. They are listed a little bit lower down. Atorvastatin, lovastatin, rosuvastatin, simvastatin, pravastatin, serivastatin, fluvastatin. Those are the generic names. And because the generic names all end in statin, even the one I didn't underline, that's why they are also commonly called the statin drugs. Now, they all have their brand names, and at least for some of them, like atorvastatin, there are now generics available. So what do they do? How do they work? What's their pharmacodynamics? What they do is they inhibit. These are an inhibitor. They inhibit an enzyme The name of the enzyme is, you don't have to know, 3-hydroxy-3-methylglutarol coenzyme A. That's an enzyme that normally converts saturated fats into cholesterol in your liver. And these drugs block, they inhibit that enzyme. So that prevents your liver from converting saturated fats into cholesterol. The result is it lowers the amount of cholesterol in your body. It also seems to increase the breakdown of LDL. Now, there are some interesting side effects, adverse effects. Many patients, quite commonly, who are on statin drugs to lower their cholesterol will report that it causes weakness and pain in their skeletal muscles. And if you know of anybody on these drugs, it's a very common complaint. Also, because their person is taking this drug, and once they start, they are going to keep them on these drugs for the rest of their life. And so, with taken over long periods of time, every single day, they can cause liver damage. The statins are the most important drugs used to try to lower the cholesterol levels, other than trying to do this, through a lifestyle change of simply eating foods lower in fats and lower in cholesterol. There is other drugs, other categories of drugs as well. There's a drug called Zetia. Has anybody ever run into that? Zetia is a drug that inhibits the absorption of cholesterol in the small intestine. So this simply stops cholesterol from even being absorbed. What did we say the statin drugs like Lipitor do? They can stop the conversion of saturated fats into cholesterol by your liver. And they have a drug called Warfarin. What's that? That combines Zetia with a statin. So basically it tries to lower cholesterol two ways. The Zetia in the Warfarin drug stops the absorption of cholesterol, and the simvastatin, or Zocor, that's combined with it, prevents the conversion of saturated fats into cholesterol. It is possible to watch what one eats, in theory, and try to reduce your cholesterol intake. I will remind you that the foods that contain cholesterol are anything from an animal. There is no cholesterol in plants. So you can eat all the vegetables and fruit and grains you want. You may have other problems with eating a lot of those things in terms of carbs, but in terms of cholesterol, there's no cholesterol in plants. But there is cholesterol in anything and everything from an animal. There's cholesterol in meat, there's cholesterol in eggs, that's from an animal. There's cholesterol even in fish, there's cholesterol in milk and all cheeses, dairy products, because milk comes from an animal. So, but even if somebody, let's say, literally became a vegetarian to cut out the intake of all cholesterol, they still can have a cholesterol problem, because our liver has this enzyme that can convert saturated fats into cholesterol. And so there are fats, saturated fatty acids, even in vegetable products, plant products. So even if somebody wasn't eating, strictly a vegetarian, didn't eat anything from an animal, the saturated fats found in plants can still be converted by this enzyme in the liver into cholesterol. Now, for most people, they shouldn't need to resort to that, but some people chose their parents not very wisely, and they've got bad genetics. They may have high levels of LDL that their liver makes, and low levels of HDL. So even when they've got such high cholesterol levels, they tend to transport excessive amounts of cholesterol to the walls of their arteries. Those are just genetically determined. On page E3, another drug that you'll run into patients taking, either as a prescription drug or just taking it because it's really a vitamin, they could just buy it over the counter as a vitamin, and that's niacin. And high levels of niacin, I don't mean the amount of niacin that's usually found in a multiple vitamin, but higher levels of niacin have the effect of lowering triglyceride levels and even lowering the LDL, the bad cholesterol, the bad lipoprotein that transports cholesterol from the liver to the walls of the arteries. We don't even know exactly how niacin does this, how it works, but some people are taking niacin. Niacin also has another interesting effect. It causes generalized vasodilation. And so if you know of anybody who takes niacin, it's very common they get flushed or they feel all flushed, they turn all pink. It just has that effect. And by dilating all the vessels, it tends to lower their blood pressure, and they're prone to postural hypertension. There are a whole bunch of other drugs. They are not as commonly used as the three that I've just described for you, the statins, the drugs like Zetia and niacin. They're listed here, but I'm not going to ask you to know about them. So we're mentioning three types of drugs that are used to lower fat and cholesterol levels. On page E4, well, we said that in addition to the fact that cholesterol accumulates on the walls of the arteries, as it does so, we said it increases the risk of blood clots. So many people who already have high cholesterol levels and they suspect are at increased risk of having these thromboses or blood clots are going to take anticoagulants. And anticoagulants simply reduce the risk of the formation of blood clots, both thromboses and emboli. Does everybody know the difference between a thrombosis and an embolism? Yeah. A thrombosis is when a blood clot forms in a vessel in the manner that we've described to you. But a blood clot that forms can then get dislodged and start to move through the bloodstream and may end up lodging and blocking some vessel distant from where that blood clot originated, where it formed. That's called an embolism. So an example that I like to give is that there is a condition known as Thrombophlebitis. And anybody know what phleb is? Vein. And so this is an inflammation in the veins. And a common location for thrombophlebitis is inflammation of the veins in the legs. And because the veins in the legs are inflamed, blood clots form. Those are called a thrombosis. Now, it's not good to have blood clots in the veins of your legs, because obviously it reduces normal circulation of blood in the legs. But what really worries doctors even more is that those blood clots in the veins of a person's legs may dislodge and start to flow through the bloodstream and end up lodging and blocking the flow of blood to the brain or to the lungs. And those would be called a cerebral embolism or a pulmonary embolism. So it's still a problem with blood clots. It just means that it didn't originate in the brain. It originated maybe in the legs or somewhere else, but it ends up lodging there. So they use anticoagulants to reduce the risk of these formation of blood clots and to reduce the risk of blood clots in the coronary arteries. That's called a coronary thrombosis. What's a TIA? A transient ischemic attack. And a transient ischemic attack, transient, anybody know what transient means? Short lasting, just transient, temporary. You know, sometimes they'll say, you know, they're just transients around here. They're just not going to be here that long. Transient means short lasting, ischemic attack. And this is really where we're getting little blood clots in some of the blood vessels of the brain, in small little blood vessels of the brain, and they're temporarily blocking the flow of oxygenated blood to the brain, causing a temporary, a very short-lasting ischemia, and that can cause the person to faint, basically, fall to the floor, lose consciousness briefly, and so that's usually a precursor to a more serious stroke, a full-blown stroke. And a stroke or cerebrovascular accident is a cerebral infarction. That's where some part of the brain literally dies. So a TIA doesn't mean that the brain area died, but it's an indication that there's circulation problems to the brain, and it's probably because of blood clots. And so, again, this is to reduce this risk. Now, in terms of evaluating blood clotting, so they have a number of tests, and the most important one is the prothrombin time. Again, the whole issue of blood clotting, as I'm sure you covered in your probably your path class or something like that, is that it's a whole sequence, a domino effect of chemical reactions, and so there's a whole lot of steps, and they just measure how long it takes for a blood clot to form. That's called a prothrombin time. A goal of the anticoagulants is to slow down this formation of a blood clot, to increase the prothrombin time, to reduce the risk of blood clotting. But of course, remember that if you reduce the risk of a thrombosis, of a blood clot, you're also causing it to take longer for normal blood clots to form when a vessel is cut. So these people who are on anticoagulants tend to be bleeders because they're on medication purposely to slow down the formation of blood clots. Now, there are a number of different categories of anticoagulants. The most powerful are drugs like warfarin. Warfarin goes under brand names like Coumadin, and dicumarol, and so on. And what warfarin is it actually is a molecule that resembles vitamin K in its appearance. Well, you may recall from your nutrition classes or other classes that vitamin K is a vitamin, a coenzyme needed for the synthesis of a number of these blood clotting factors or blood clotting proteins in the liver. So if this Coumadin, it resembles vitamin K, it competes with vitamin K, and it basically reduces, it interferes with the synthesis of these blood clotting factors or proteins that require vitamin K as a coenzyme. So basically the idea is this: with decreased availability of vitamin K, there's a reduction in blood clotting factors, and therefore reduction in the formation of blood clots. When somebody starts taking warfarin, this effect does not occur immediately. It takes a few days for them to start to see this reduction in blood clotting factors and a slowing down of blood clotting. And similarly, when they stop taking Coumadin or warfarin, it takes several days for the effects to go away. So if somebody was going to have surgery, they might not want them to be on anticoagulants because they're worried about during surgery they're going to bleed to death. So they would tell them to go off that warfarin medication maybe a week or more before the surgical procedure. Anybody on these anticoagulants in general, but certainly drugs like warfarin, may exhibit spontaneous bleeding and hemorrhaging. On the next page, on E5, under clinical considerations. So again, if somebody is on anticoagulants like warfarin, be alert for abnormal bleeding, including hematuria. Anybody know what hematuria is? Blood in the urine, blood in the stool, petechiae, bleeding gums, nosebleed, and excessive menses. These are all not uncommon in somebody on anticoagulants, especially the powerful ones like warfarin. And you can see that when they want them to go off it, they actually wean them off it gradually. And what they actually do if somebody takes too much warfarin, since it's interfering with vitamin K, the antidote to taking too much warfarin is to give them vitamin K. And that basically helps take away the effect. In the hospital setting, they give heparin. And heparin is a drug that also is an anticoagulant. It specifically interferes with factor 10 in the blood clotting sequence. I'm not asking you to know that. In fact, I'm not even asking you to know heparin at all, because heparin cannot be taken as a pill. Heparin has to be given by IV drip. And therefore, while heparin is commonly used in the hospital, it's not something that a person takes at home, because it's only, it can't be taken as a pill. Another category of anticoagulants are drugs that interfere with blood platelets. Now, we had said that blood platelets are these little guys that are designed to attach or aggregate. They attach onto rough surfaces of a blood vessel, whether the blood vessel has been cut or it's got atherosclerotic plaque. So there are a number of different drugs that interfere with the platelets attaching to the rough surface. And the most famous of these is aspirin. So aspirin is an anti-platelet drug. It's called an anti-platelet drug. It's not interfering with the blood clotting factors. It's interfering with blood platelets. Does everybody follow the difference? Warfarin reduces the formation, the production of our blood clotting factors or proteins, like prothrombin. Aspirin, as well as Plavix and Anticoagulants, are anti-platelet drugs. They interfere with the aggregation or attachment of the platelets to the rough surfaces of a vessel, and therefore, remember, they have to attach to the rough surfaces of a vessel to release platelet factor to initiate the blood clotting mechanism. All right, so you should be aware of these two major categories of anticoagulant drugs, the drugs like warfarin and the drugs like aspirin, which are antiplatelets.